Good afternoon, everyone. My name's Stephen Liversedge. I'm actually here with two colleagues from NHS Bolton, which I'm going to talk to you about. And if there's any difficult questions, my two colleagues would be delighted to answer them afterwards. And we're going to talk about our Triple Aim experience in Bolton over the last 3 years. And you're going to hear about health inequalities in Bolton and population health and how we intend to deliver better care for the population of Bolton. And there's quite a bit in it about transparent sharing of data between practices, transparent sharing of best practice between practices, engaging with practices, and some examples of the projects and the outcomes which we've produced in the last 3 years. So here is Bolton. It's in the northwest of England, part of Greater Manchester. It's about 10 miles wide and 10 miles long, has a borough population of 265,000. Has 50 practices, 50 GP practices in it. Although it imports patients, and we talk about the Bolton registered population of being 290,000 patients. And this is a map I show for two reasons, not just to orientate you to the Bolton surrounded by Blackburn, Bury, Salford and Wigan, for those of you from England. But it is what I call the map of Bolton. This map actually shows mortality from circulatory disease, and we have an unenviable record for that, much greater than the northwest average, which is much greater than the England average. But it's a map of everything in Bolton. It's the map of smoking. It's the map of diabetes prevalence. It's the index of multiple deprivation. So anyone with public health background or interest amongst you will know that, because I'm sure that's replicated. So we have central deprivation, high disease prevalence, and outer areas of relative affluence. And all primary care trusts, as we were, still are I suppose, were tasked with addressing health inequalities. And as I said, Bolton had an unenviable record, 2-year gap in life expectancy compared with the rest of England. And even more embarrassing for clinicians is that within the borough there were massive differences. You could live 2 miles apart and have a difference in life expectancy of 15 years, so we always refer to the two gaps. And we've always known the biggest contributors to the gaps: cardiovascular disease and diabetes. And also a lot of smoking, a lack of exercise, a poor diet, and a lot of obesity. And a primary care system that wasn't really interested in preventative strategies at all. It was just interested in dealing with firefighting. And so decided just slightly before Triple Aim, if truth be known, that we needed to do something about this. And I'm going to use this as my first illustration of what we did and what we learned from it. And it became known as the Big Bolton Health Check. And in a nutshell, it was to make sure absolutely everyone in Bolton providing care engaged in a project to screen the population over 45, as it was decided then, without existing heart disease or diabetes, to look at their risk of CVD in the next 10 years. And that was the project in a nutshell. And we already knew that some of this work was going on, but it was going on in rather desultory fashion. Some practices were engaged in it, and some practices very definitely weren't. They didn't think it was part of their job. And back in 2006, we reckoned, or practices who were engaged in it told us that about a quarter of the population, there's 89,000 people in Bolton over the age of 45 without existing heart disease or diabetes. And practices told us that they reckoned there were about 25% of those had the data to do the risk assessment. Hadn't necessarily done it, but they had lipid profiles, smoking histories, family history and the like. And so we modestly incentivised a scheme for them to do more. Again, not all practices joined in, and we made some progress, but then they started saying, it's really hard. This is really hard. People won't come in. There's nothing wrong with them. That's why it's primary prevention. They won't come in. They're not interested. And that's what really the moment that I thought, if we all join in and we all do it, we can make some inroads into this. And inroads we made, because that was the before the big Bolton health check graph, and that's the after. So what actually happened in 12 months was every practice joined in, lots of support from the Primary Care Trust, lots of support from our team, which I'm going to talk to you about, and it caught the imagination of the public. We had stories in the newspaper, stories on the media. We kept the whole thing going. In fact, it passed into the vernacular, really. It's probably an apocryphal story, but they say an ambulance man rushing to someone collapsed in the street, his first words were, "Have you had the big Bolton health check?" But it's certainly, you couldn't find anyone in Bolton who didn't know what the big Bolton health check was. And so we ended up, at the end of that year, screening 83% of the population, 79,000 people, which we were very pleased with overall, and rather thrillingly got some outcomes that were perhaps far in excess of what we expected. These are the emergency admissions to our local hospital. We only have one hospital trust, with a diagnosis of acute myocardial infarction. Now, as many of you know, those have been falling, but nowhere near at this rate. So I've highlighted where the health check began, and they've come down quite spectacularly. So we were pleased with that, and even more pleasing, because this is where I came from, was that eventually the CVD mortality appears to have adjusted downwards, which is where this all came from. So we're very pleased with what we've done. So we want to tell you really what we learned from that and how we've expanded it. So what worked? Lots of things worked, but I just want to highlight some things. Clinical leadership and managerial leadership closely allied, and our managers are here with me today, closely allied, knowing exactly what we wanted to achieve and how we were going to achieve it. And the engagement with practices, 50 practices, was very, very crucial. And we learned quite a few things about it, about engaging. It's not a question of going to practices and saying, you should do this. It's a question of going to practice and saying, we've got a problem. What do you think we should do about it? So suggest what's important, show them why, the two gaps. What are we going to do about it? We're going to do some serious primary prevention. We did a lot of gathering data from practices, and I'm going to talk a bit more about that, as you'll see. But the very crucial thing that our little team did was change the data into information. What's my definition of information? It only becomes information if it's going to change behaviour. So there's loads of data in the NHS, but most of it is a waste of time. It has to change behaviour. And you'll see some examples of that. I'm going to show you something about peer clustering, which modestly I can say I invented. An incentive scheme, which was slightly unusual. And the other thing that worked, and is a very important aspect of this, is not saying to practices, we agree this is the problem, you get on and do something about it. It's saying to practices, what can we bring into your practice to help you do it? Support, and a very big resource that we had were 28 health trainers. A public health resource, came from the local communities with people skills, trained in behaviour modification around diet and exercise, weight management, stopping smoking. And I asked and was given, we asked for and were given that resource, and we actually trained them in physiological measurements, taking blood, blood pressures and the like. And we could run a lot of events, outreach events, that publicised. It wasn't that the outreach events generated the numbers, primary care generated the numbers, the outreach events generated the publicity. So we could go to unusual places, betting shops, pubs, mosques, anything where there was the so-called hard-to-reach population, and start publicising the Big Bolton health check. And it worked very well. And then the other thing was to be sensitive to what practices were telling us all the time. And practices were telling us, the difficulty is, if we don't take blood samples in the morning, we can't get them to the lab in time. So it was a question of talking to the lab, and the lab said, we'll open late. We'll stay open later, you can take samples whenever you want. So it's a very important issue of listening to the practices and saying, what are your problems? And then saying, we'll sort those out for you. And we did a lot of practice visits. There was a question this morning in the session at Roberts was part of this morning, about how do you engage with practices. Well, how do you think you engage with practices? You go and visit them, right? And you talk to them. Or before you talk to them, the best thing to do is to listen. Because you may come full of enthusiasm about what's got to happen, but it's best to listen first, because I might be talking about health inequalities and Bolton's reputation, and the practice might be saying, well, actually, I've got 250 asylum seekers and 57 different languages. So you have to hear what their problem is first before you can start addressing what I perceive to be my and our problem. The other thing that we quickly realised was you had to do quite a lot of education. I'm sorry, right, but there's big variation in primary care. And you had to do a lot of education, and you had to simplify a lot of it. It had to be things that practitioners could hold in their head and do in the middle of busy surgeries. And that required some simplification. So it's no good producing algorithms of how to manage chronic kidney disease and have a section about bone disease, because primary care are not going to deliver that. You have to simplify it down to what they do. Mentioned a lot about supporting the practices and facilitating it. And then another big thing was, some practices do these things really well. Just go and find out how they do it and bring it to the practices who are doing less well. And ideally, pretend that I thought of it. Okay? And that worked really well, and a lot of comparison and contrasting of performance. So I'm going to show you a bit more about that. This was the incentive scheme. Of course, you have to incentivise, unfortunately, financially incentivise practices to do new initiatives. So devised this what I call logarithmic incentivization. The mathematicians amongst you will realise that's not logarithmic, but you will get to the principle that the more you do in terms of achievement, the more you get. So it wasn't about saying, do this risk assessment and we'll give you X pounds for every one you do. It was about, if at the end of the year you've done 80%, you'll get X pounds for each one. But if you've done 90%, you'll get even more for each one. And that did push practices on, not to stop at a certain point and congratulate themselves. The further on they went, the more they got for each element of which they've done. And we're using that again because, believe you me, it worked. Now I want to talk a little bit about this peer clustering. I'm for my sins, the pet chair in NHS Bolton, have been since its inception. So over the course of the years took quite a lot of issues out to practices about performance, basically. Too many A&E attendances, for example, or too many paediatric admissions, low breastfeeding rates, all sorts of things. But what happened was there was always a ready reason why their performance wasn't good. It was because their practice was big or their practice was small. That's always a nonsense, by the way. It was about the fact that they had a very old population or a young population, or they had a lot of minority ethnic community patients, or they were very deprived or very affluent. So there was always a ready reason why they were allowed to perform not as well, why they didn't quite need to engage in any initiative. So we had to get round that, and I'm surprised it took me so long to think of it. Okay, the answer was, of course, to make sure that you compared apples with apples and pears with pears. And for 10 years, we've always had completely unanonymised practice information in the public domain. So we haven't had any problems with not being able to name practices and letting anyone access the information. So here is peer clustering. Don't study the detail. Marvel at the panoply of colours, which the astute ones amongst you will realise approximate to some degree to the colours of the rainbow. Although the historians and scientists among you will know that Isaac Newton said there were 7 colours in the rainbow, for reasons that aren't entirely clear, because no one can tell the difference between indigo and violet. Anyway, the clusters are named after the 6 colours I can recognise. Richard of York gave battle in vain. Red, orange, yellow, green, blue, indigo. Okay, got the principle of it? Just a name, it went down quite well. But these are practices who are clustered according to their demographics. So along the top, don't worry about the detail. We can see list size, the average age of the practice, their ethnicity, i.e. the percentage of people from black and minority ethnic groups, their index of multiple deprivation score, and various descriptors. And as I looked at all that information, it was obvious that there was a little cluster of practices, who are now known as the red cluster, who had very high deprivation scores, between 42 and 54, and over 50% of the population were from black and minority ethnic communities. In Bolton, the main minority ethnic community from the Indian subcontinent, India and Pakistan predominantly, and slightly unusually, the vast majority of them are all Muslim, even the ones from India, by the way. So those practices clustered together. And then down at the bottom, chalk and cheese, affluent practices, almost exclusively white, very low deprivation scores. So it's quite pointless comparing, taking borough averages when you have 2 such disparate groups. And then in a fairly straightforward way, I clustered the orange and yellow as practices that had more than the borough average of minority groups on the basis of their deprivation, and clustered the green and blue, who were again almost exclusively white on their deprivation. The main point about this is the GPs, the practice nurses, everyone got it and agreed with it. So whereas before they could give reasons why their performance wasn't comparable with anyone else, they could completely understand why it was comparable with their cluster. And to this day we use it for virtually everything, prescribing, any performance issue, and the practices like it. So what did we do with that? We then, having established that principle, took the issue of primary prevention and started comparing peer averages. So we could look at the red cluster at any one time and see that this was actually at the end of the Big Bolton health check. They had risk assessed 83.6% of the population. But more importantly, we could see who was below that. And this is about changing data into information, because it's all very well getting this stuff and we got tons and tons of it. It's what you do with it. And the sort of thing you do with it is change it into this. So this was a few months into the Big Bolton health check, and you could see a practice, this one, who said, this is really hard, our practice population don't want to come for these checks. But of course we could say to them, there are other practices like this one who are doing very well. But most importantly, this isn't to chide or challenge, it was to go to the practices who are doing well and say, how have you done it? What have you done? And they tell us things like, stop sending out letters, right? Get a receptionist from the practice who knows them, knows the family, to phone them up and ask them to come in. Or subsequently find out why they haven't come in and deal with the issue. So we could always share, as I said, best practice, and we could also target our support where it was best needed. So anyone who wasn't doing well, we didn't say you're not doing well, they could see that from this, but we could say what could we do to help. So we could run some targeted sessions for them using the health trainers. So everyone got an idea that we were kind of all in this together. And it worked really well. So we expanded it. Again, I apologise for the busyness of the slide, but it's the principle I want you to see, into all sorts of other disease areas. This was after the Bolton health check. This is actually the one about chronic kidney disease. And again, Bolton had a reputation that was not good in terms of its identification and management of chronic kidney disease. And these are what we call the Triple Aim sheets, because they cover a whole variety of disease areas: CVD, diabetes, CKD, COPD. And along the top we put key indicators of performance. We always peer average it out, and we highlight practices who are 10% below the peer average. And we send it out to the practices. Don't have to do anything else, just send it out. And practices don't really like being an outlier. They don't like it. And they generally ask, how do we stop being an outlier? And we start addressing it. And on different sheets we will put different things. Everyone said, if you're going to improve your registers of chronic kidney disease, you're just going to increase nephrology referrals. But actually, because there was we always surrounded the whole process with education, nephrology referrals went down. So we did feel we were hitting the elements of Triple Aim. And here's another outcome, which I have to say we're very proud of. Back in 2006, Bolton was at the bottom of the Greater Manchester League table of chronic kidney disease, and the renal czar was not thrilled with us. However, we now sit comfortably, it's not completed the year yet, at the top of that league table. And the management of chronic kidney disease and the analysis of it by Bolton practices is second to none. All practices code all stages of CKD. They code proteinuria and analyse proteinuria, undiscovered learning points, the black and minority ethnic community. Proteinuria rates in CKD, 12%, compared with the white population, 3%. And that will have a big outcome unless we address it. And practices are now treating the patients with proteinuria to lower blood pressure targets. And this will have a big difference to our outcomes. So we started off, there were just 3 of us, but our team expanded, and it wasn't too difficult to get all practices bought into this principle of triple aim. That, and I often use this, it's not really an analogy, but you'll understand it. In the 1980s, as GPs, all we did was the very best care for the patient who sat in front of us, and we didn't really care about anything else. In the 1990s, we became aware that money was finite, so we had to pay some attention to costs. But the real goal for any healthcare organisation is the health of its population. So practices got that and understand it. And then we put patient-centred care, which I know Maureen would say is at the part of better care, best care. We put a little triangle in the middle to say we've got to make sure our care is patient-centred. And because our outcomes have been good, it's not been difficult to attract resource to support the whole initiative. So we've moved into other things. First thing is to make sure that every practice's registers are right. It's all very well practices saying we've got every QOF point in COPD, but not if half the COPD patients aren't on the register. So we worked hard about prevalence. We've done a big piece of work about identification of people at risk of developing long-term conditions. That's not just primary prevention. Our primary prevention registers grew by 10,000. It's about impaired glucose tolerance as well. I'm going to tell you a bit more about that. And also, we've started now ensuring that the people who are on the registers do get the best care. And I'm going to show you something about that. Again, a rather busy slide, but actually practices told us this was what they wanted. So they had all these sheets with this information on, but they wanted something a bit more focused. So this is an individual practice report, and it takes various disease areas, some of which I've touched on, and puts the key indicators at the top. Anywhere that goes grey, they're below the peer average. So they can have a look at how much below and why. But they also wanted to see, and I think this is very reasonable, where they were improving. So quarter by quarter, we could say anything that's green, you show an improvement. And again, it's more about this message of not chiding practices for what they haven't done, draw their attention to what they haven't done, but congratulate them on what they have done. We now don't have initiatives, so many initiatives where everyone's doing the same thing, because different practices have different initiatives. So where we had a practice that still hadn't done enough primary prevention, we said to them, come on, let's have another go at this. So here is a practice where their primary prevention screening was about 70%. We said, well, we really think you ought to get it up, big practice, back to 75% over the course of the year. And this was, again, another way that we learnt in the Big Bolton health check about showing practices how they were doing. We drew a trajectory and kept feeding back how they were doing. Here's another example, perhaps a more typical example, a practice that had a very poor heart failure register, 0.4%, should definitely have been more than that. Decided on a more appropriate target, and they said, okay, we agree, we'll go and do some work on that. And after 3 months, what was the result? Absolutely nothing, because they hadn't done anything. So we were back. And not to say you've done absolutely nothing, that was self-evident, but we were back to say, this is what we think you should do next. We'll cross-reference your heart failure register with the hospital's heart failure codes for your patients. There were gaps. We'll search your computer system for all the echoes that have been done. There were gaps. And then finally we said we'll search your computer system for medications and identify the missing patients. So they're all there, they just weren't coded. But if they weren't coded, no one could possibly have known they were getting the right care. That was a kind of good example of our methodology. Best care projects. So a lot of work surrounding prevalence, as you can see, but how can we be sure that the patients on the registers are getting the best care? Well, we have the QOF in the United Kingdom. A good start, but not great. Not great. They allow exception reporting. They allow targets of less than 100%. So we wanted to get round that, but we wanted to simplify it a little bit, as I think you'll understand. So for these 3 disease areas, CHD, diabetes and COPD, chose 5 quality indicators and said to practices, well, actually interrogated their computer systems, how many of your patients hit all 5, or 4 of them, or 3 of them, or 2? But again, the principle was just to find out where we were and then decide how we were going to change it. Fairly straightforward, 5 indicators for CHD. I don't think there'd be much argument there. How many aren't smoking? How many have blood pressure to the QOF target, whether you agree with it or not? How many have a cholesterol less than 5? How many are on a beta blocker? And how many on an antiplatelet agent? Fairly straightforward. And this is the borough picture, or was, so this is a before and after, the blues before, the purples as of December. And you can score these graphs. So you take the percentage that have 5 and multiply that by 5, and the percentage that have 4 and multiply it by 4, etc., and you come up with a score. And Bolton's score was 323 at the start, but you can see it's come up now to 375. Not bad, but quite a lot of variation between practices. But the main point is all practices have improved because they get the principle of if 71% of your patients with existing CHD are on an antiplatelet agent, why aren't the other 29%? Well, of course, some of them might be intolerant or allergic or whatever, but not 29%. So they started systematically looking at the registers then and searching for these patients. And you can see that each one of those 5 indicators have improved across the borough. And every practice gets feedback about how they're doing. And this is an example of best practice. This is a practice that actually scored 400 at the start of the year. And this is a red cluster practice. This is a highly deprived practice. Majority of them speak Urdu but can't read it. Okay. And look at his score, 413. So you can use him as an example to the other practices in the cluster about what can be done. COPD indicators, fairly straightforward, but not the QOF ones. 3 new ones, and this is what determines hospital admissions. Can they use their inhalers properly? Have they got proper spirometry, and have they got a management plan? And again, we've had poor starting place, but significant shift of the graph to the right. I think you see the principles of this now. Every one of those 5 characteristics improved across the borough. Here's a practice, very low starting point, terrific shift to the right. Okay, terrific shift to the right, systematically going through the registers. Diabetes, I'm not going to dwell on. Same principle, big improvements. And again, another practice, spectacular scores, actually an affluent practice. And the final thing I just want to briefly talk about is impaired glucose tolerance. Not in the QOF, ignored by most areas, but there's a tsunami of diabetes approaching us. And we've got to be doing something about it. So it was really a question of simplifying identification of impaired glucose tolerance and diabetes for that matter. Get a blood sugar off all your patients. If it's over 5.5, do a glucose tolerance test. Get everyone doing the same thing. And Triple Aim sheets, identify who was doing well. Showing things like the screening, the number over 5.5, the number of glucose tolerance tests, and their prevalence. But then most importantly, don't saddle practices with extra work. Have something in place to address it. And this is fairly spectacular, so I'm going to end on this. Referred them to the health trainer. 120 patients under evaluation. Intensive intervention by the health trainer. Health trainer might go to the patient's home, might open the cupboards, might open the fridge, might take them shopping, okay, might show them how to cook. But 65% of them have reduced their 2-hour glucose, and 51% of them have lost their impaired glucose tolerance. So it's not an inevitable progression. I better stop there. Robert's fidgeting.
Thank you very much indeed, Stephen. We have a good 5 minutes for questions. Because of the layout of the room, if it's all right, if you could put your hand up, I will come to you with the microphone, and we'll get that started.
Thank you. So I'm Jim Gardner. I'm a GP in Lancaster in the northwest of England.
Yes.
Stephen, thanks very much for that. I think the thing that I want to ask is about incentives for general practice. Yeah. To be honest, in some ways I find it sort of professionally insulting that my profession needs some financial incentives in order to do the right thing. We're spending taxpayers' money, we're responsible to the taxpayer in whichever country we work, and we've seen in our own hospital system that we've moved to sequin, which is more about penalties in actual fact than incentives, and we've also seen politicians and our own SHA chief executive struggle in the media to explain why clinicians need financial incentives when pilots don't and others. So do you think we stick with this track, or do you think we try and change it in some way?
Yeah, great question, and I agree with you entirely. except I am completely and utterly outcome focused. And the point was, we weren't getting what we wanted, health inequalities, and the investment actually is modest. You know, Bolton has a budget of £500 million, and the incentive scheme spent 490,000, peanuts, to identify 19,000 people at high risk and halve the number of events. So, outcome-based, cost-effective, but you're absolutely right. Many of my colleagues would say, isn't this the day job? We're carrying on with it for the time being.
Hi, Liz Fitzmaurice from New Zealand. Just a question, is there evidence in England down track about financial incentives, whether it's sustained change or whether it's short term? Because I guess that's my gut feeling, that as soon as you stop the money going in, if that's why people did it, they won't continue to do it.
Yeah, what we've done is we switch the scheme every year to get, you know, new stuff going. So we stopped that incentive scheme for primary prevention. Perhaps this is back to Jim's point. Stopped the scheme thinking it was embedded and it would carry on. What happened in the next year? Started for 10. Everyone stopped doing it. Okay. But we switched on, we moved on to these other schemes. This year we've got 19 different schemes going. So I just use the same money every year to get a new outcome. And on the whole, most of them get embedded. On the whole. Okay, so the CKD work is embedded. Okay. So it's a difficult issue, and it depends where your philosophical, ethical and outcome standpoint is. As I said, I'm outcome. So that's what we do in Bolton, but other areas don't.
Thank you. Gentleman here.
Yeah. I'm Fleming from Denmark. How have you dealt with malfunctioning practices?
Spent a lot of time with them. There's always a reason why they're malfunctioning, and say we're here to help. So there's no semblance of being occasionally amongst the three of us. We adopt a slight nice policeman, nasty policeman approach to the issue. One of us is a bit uncompromising, and then the other one's a bit sweet and kind. But on the whole, we are perceived as a help. And so we have a practice at the moment who was referred to NCAS, for example. And we went to the practice.
What is that?
It's a process before you're severely punished, where a support team come in and analyse what's...
Principle.
Yeah. And so we went to the practice, identified all the metrics, came up with a plan, came up with a programme of support, and said, we want this to happen, we'll help you. If this doesn't happen, you're back on your own. But of course, behaviour changed. A lot of education is part of this.
Thank you. Hi, Grant Robinson from South Wales. I wondered if you could say a little bit about the data, because I noticed there was some investment in data handling, and the outputs here look really nice, but they're a little different to what I'm used to seeing. So I wonder if you could just explain a little bit about how you developed that.
It was really just a question of going back to that point. We can interrogate computer systems because practice is letters. We can write MyQuest queries, don't want to get technical, but we can interrogate almost any practice system, and practice is letters. We can remotely interrogate 70% of practices systems. And it's all about converting the data into information that will change behaviour. So we devise the sheets. Everything that you have seen has been devised by the three of us. And our information person extracts it and puts it into the form that we want to change the behaviour. and we modify it on the basis, I showed you one where practices asked us to modify it. We put data in, sometimes take data out. So it's individualised, but every practice gets the same stuff.
Well, I'm conscious of the time, and I'm afraid I'm going to pause it there. Do feel free to come and speak to Stephen, Linda, or Leslie afterwards, because I think these, yeah, they're up front here. I think these are some great results and really encouraging, lots of food for thought, and I'm sure actually lots of opportunities for further questions. So if you have a further question, please do come and ask it afterwards. But let's just thank Stephen, Linda, and Leslie.
Thank you.
Thank you very much. I'm going to ask Jozé and another Stephen now to come up to the stand as Jozé is just getting her presentation ready. We're going to take the same format here, so they're going to present and then we'll have questions afterwards. And I will let Jozé introduce herself.
Thank you very much. Thank you very much for inviting me over here. We would like to share with you experiences on, you could say, pay-for-performance programs and accreditation programs in the Netherlands and in the UK. We called our workshop Transparency in Primary Care, Balancing Between Policy, Practice and Science. And as you can see, my name is Jozé Braspenning. I'm working in the Netherlands at an institute called IHI Healthcare, and it's related to the University of Nijmegen. And Stephen Campbell, who is the next speaker in this workshop, will present himself, but he's working at the University of Manchester. An overview of what we would like to do in this workshop is I'm taking you a little bit to purposes of measuring quality. I would like to share some thoughts about formative and summative assessment and intrinsic and extrinsic motivation. Then I have a whole presentation about Dutch experiences, and Stephen will take over from there. Why are we measuring quality? I think there are a lot of reasons why we would like to measure quality. First of all, you could say quality measurement can be a basis for quality improvement. We can compare ourselves and it can stimulate and motivate practices for change. Another purpose is that we have to do it because we're in all kind of pay-for-performance programs, or there's just a reward for perceiving some kind of level of performance. Another purpose could be regulation. We all have to follow the minimum standards. Or perhaps we are working in a system in which it's very important that purchasers can buy their care based on quality measurements. Or perhaps we are just interested in identifying areas of future investments. Or perhaps we just like to inform service users, patients, consumers, the public. Anyway, clear purposes is needed, because only when we have clear purposes we can make and come up with clear criteria by which to judge subsequent success. How can we measure success? First of all, when we have seen all these purposes, perhaps we can divide them between two important differentiations. Some of them are about summative assessment. It's the assessment of learning, what we all have done in school. Do we pass? Do we fail? But there is also formative assessment. That is the assessment for learning. It's non-judgmental and it's educational. We would like to stimulate the practices, never ever give up. So we need some kind of motivations. The caregivers, you could say, are the producers of all the data. They are the data diggers. But why are they doing this? Is it just intrinsic motivation? Is it what you may expect, as the person in the audience just showed us, that he says it's just a professional wanting us to do it? Or is it just that there is some control from within ourselves? We need some reflection on our own work. But of course there's also this extrinsic motivation. It's someone else tries to make you do something. So the motivation is external to yourself, like all kind of pay-for-performance programs. How do these two relate? You could say, when we are in a world with a lot of formative assessment, that promotes the intrinsic motivations. The professional wants to do them for themselves. But then you're more in the surrounding of summative assessments, that promotes extrinsic motivations. And I think that has consequences for public reporting and quality improvement in general. And when you look at this scheme, you can see some of these consequences. I just came up with a few. When we are looking at data collection, you could say, okay, when I'm intrinsic motivation, data collection, it helps me to improve my administration. Electronic health records become more and more complete, and people can find the right things in the right places. But when you're extrinsic motivated, you could say, okay, I need some data, where can I get them? Perhaps there is some kind of administrative data system in my nearby, and I can use these data. When you're looking at the reliability of the data or the indicators, you could say when your intrinsic motivations, okay, there is some aspiration in it, let's come up, let's make good indicators, let's try the set now, but we want to have the next year better indicators. But when you have some kind of motivation from outside, you say, oh, these are lousy indicators, they never can come up. It's an excuse. And when you think of the effect of feedback on the quality indicators, you could say when you are motivated by yourself, you handle them and say, okay, I can start improvement programs from that. But when you're motivated from outside, there's only one way you are motivated. You just want to have better data. Perhaps not better care, but better data. So the stimuli for quality improvement, you could say, when your intrinsic motivations is more from the professional attitude, perhaps a quality mark, and from the outside, it's just money. When we think about that, you could say, okay, looking at the practice, perhaps the practice is more or less some kind of system learning, is more kind of system learning on the patient care. In the practice, people are intrinsic motivated. They're interested in formative assessment, isn't it? But when you look at the policy, you could say, well, system learning is more on inspection and control. It's more about extrinsic motivation and summative. And we can question ourselves, is the one more important than the other? Perhaps we can take some time for it now. Just share your thoughts about it with your neighbor for a couple of minutes. What is more important? Okay, I would like us to go on now. Please keep your thoughts. We want to come back at the end of our presentations because we like to have some more input for these thoughts. And this input is coming from our experiences. For instance, in the Netherlands, we had an accreditation program for the general practitioners. It started in 2005. It was a voluntary program. It had a 3-year cyclus. Things that were asked had to do about clinical care, practice management, patient experience. The practices had to come up with a smart improvement program, and the improvement program, that was the one that has been accredited based on the judgment of an independent reviewer. The improvement program had to be a good one, and we should have seen some accomplishments in the follow-up year. When we're doing the data collection, I think it's nothing new. It was about the chronic care, you could say, influenza vaccination, uptake, cervical screening, and some medication. The data collection actually took a lot of time for these people. They all had an electronic health record system, but they didn't had all these data, you could say, in the right place, in which case it was easy to get them out of them. So we advised them it was okay just to have a sample of it. And what you could see in this accreditation program is that some people really didn't come up with only a sample, but they did their whole population of, for instance, diabetes, because they were internal motivated to do it. And it actually helped them to improve the administration. We had little discussion about the reliability of the indicators, not because there was no discussion, but they said, okay, let's do this, let's have step 1 and let's try it. They also were very interested, and I think that's what you called the peer references. They were interested in stratification in the near future. They didn't care much about the number of cases, but they were actually interested in having feedback, because based on the feedback they could go on with the improvement plan. Was it effective? Well, you could say the effect was within the program itself. It is some more or less an implicit effect, because joining the accreditation program, you were working at an improvement program that was accredited. People got the quality mark, and there is a list of accredited practices available in the public domain. We also had an experience with pay for performance. Again, it was a voluntary program. The performance measurements were more or less the same as the ones in the accreditation program, and we had a lot of discussions with the general practices and also with the payers, in our case the health insurance companies, about the appraisal. It was decided that we had relative scores, so the comparison was relative. You didn't have to get to a certain level, but it was compared to the other ones. But they say clinical care should be appraised twice as much as practice management or patient experience. And we also had a discussion about the appraisal of quality level or quality improvement. And it was decided to appraise both of them, but quality level was appraised 3 times as much as quality improvement. And also the reimbursement was decided on, and they decided it should be somewhere between 5 to 10% of the yearly practice income. Now, what did we learn on the data collection? It was decided that the outcome indicators weren't included in the pay for performance system. But it was also decided that I was able to get some data on it, because they were interested in the data, but they weren't interested that it was within the pay for performance system. I had a lot of discussions by telephone on the definitions of these quality indicators. And on the practice management side, the practitioners were very much motivated. They even had all kinds of lists of equipment, and when it was showed up that they didn't reach this equipment, they right away started to get it. We also had lots of discussion about the reliability of the indicators. I had to discuss the case mix, and they say, okay, it's especially linked to outcome indicators, but we are also interested in the case mix discussion on process indicators. I had to decide things about the number of cases that were really needed to come up with precise scores. And also these general practices, they asked me to set up some kind of control system because perhaps they were collecting the right data, but what about the neighbor? Was it effective? Well, it was more or less effective, you could say. Clinical indicators came up within these 65 practices with 10% and practice experience indicators without 5%. Although I don't have really a control group, so I'm not very sure if I can say, okay, it all has to do with my pay-for-performance system. Although there is some circumstantial evidence, as is shown in this picture, because what you see here is that I also had an effect on the outcome indicators. So the outcome indicators weren't part of the pay-for-performance scheme, but they all moved up within a year period. And these are the ones on diabetes and cardiovascular risk management. So where are we now? You could say within the Dutch experience, we're really searching what to do. Trust moved away to control. Accreditation, should we move it to P4 or perhaps we should move it to some kind of certification and have a discussion about the minimal standards. But what is for sure is that there are all kinds of stakeholders who are demanding of us data in the public domain. Patients, consumer professionals, inspectorate, health insurance companies and government, they all want to have us data within the public domain. And you could say we are a little bit struggling in what kind of system we would like to have it. Is it more that we want to stimulate the intrinsic motivation or the extrinsic motivation? So from here, Stephen will take over.
My presentation's not here. We'll try again. I want to take up the story from a UK perspective, and I think this was the key slide that we're showing. There's an issue here between trust and control. How much do you leave a professional, and I often encourage a professional to look up the word professional, to do their job. And I actually do agree with this statement that was made by one of the questioners about paying a professional to do certain things which should be part of their daily routine. Except I sometimes think a patient who goes through a general practice anywhere in the world deserves a certain standard of care. Not a minimum standard of care, but a certain standard of care. And there are certain practices who don't achieve that standard of care. So there is a need for external scrutiny and there is a need for external motivation. But the internal motivation, professional motivation, is in my view what makes a professional. And that's what I'll come to at the end, and I'll try not to be too rhetorical about it. But the balance here is between summative assessment of learning, pass or fail, and in my view that's the fundamental problem of things like the Quality and Outcomes Framework. I'm a big fan of the Quality and Outcomes Framework. It's paid my mortgage for the past 10 years, but it has some fundamental flaws, one of which is it simply operates on a yes or no basis. For single conditions, when patients have more than one condition and they're quite complicated. So trying to embrace that complexity has to be the starting point for a quality indicator. Contrasted with formative assessment, which is assessment for learning, and I'll come on to that when I talk hopefully about practice accreditation, if the slides allow me to. Yes, good. Okay, so the Quality and Outcomes Framework. Now, everybody knows about the Quality and Outcomes Framework. It's probably well past its best before date. The really important statistic on that slide is the bit in red, which is how much of a practice's income is attributable to the Quality and Outcomes Framework. 25%. It's somewhere between 25 and 30%. In my view, that's way too high. It should be no higher than 10%. So I was interested in José's, it's between 5 and 10%. If you look at most HMOs in America, their P4P schemes, it's between 5 and 7%. So in my view, below 10%, because as soon as you start getting to 25 to 30%, it stops being a pay performance scheme, it stops being a motivational scheme, and it starts becoming part of the day-to-day payment of the practice, and it's far too high. Now, the other thing about the Quality and Outcomes Framework is it's voluntary. So practices don't have to do it. 99% of practices do it, partly because 25% of income is attributed to it. So it's in my view, just too high. It's mostly about clinical indicators, it's mostly about process indicators, so not outcomes, as Stephen was saying. And it nets the average GP or GP partner, if they're an equity partner, so they own part of their practice, a certain amount of money per year. Approximately 40%, I think, of GPs in the UK now are salaried GPs, so they don't take home the additional benefit anyway. Now, what I want to do over the next few slides is raise certain issues about extrinsic pay-for-performance indicators, and there are certain just key messages. Here are the data for the first 5 years of the Quality and Outcomes Framework, and as you can see, it's all on the right-hand side. There were high levels of achievement to start with, and it stayed high. The interesting point is that's where the government expected the first year achievement to be. So from year one onwards, achievement was far higher than the government expected. Now, this comes down to the other key message that José said in the introductory slides about purpose. If the QOF was about improvement, it failed from the start, because for most indicators, there was nowhere to improve to. If it was a payment mechanism to reward high quality care, it ticked the box. Whether you think they were the right things to incentivise or not, it did okay. But from an improvement perspective, there was nowhere to improve to. So that's message number one. Message number two is try and know what your baseline is before you start attributing so much money to things. Because this caused PCTs an enormous amount of problems because they had to pay more than they'd expected to have to pay. And this is just a handful of slides about the diabetes indicators, and these are what we call the bookends. So on the right-hand side are the achievement rates, on the left-hand side are the exception reporting rates, very few patients accepted, very high achievement rates. I think it's 8 indicators have just gone out of the Quality and Outcomes Framework, thankfully. In my view, they should probably never have been there. For example, patients with hypertension who have their blood pressure checked. In my view, you should not be incentivising a professional to do that. But these are the kind of indicators which had very high levels of achievement, very little exception reporting. But again, if it's a quality improvement scheme, there was nowhere to improve to. So this is about, if you're going to have a P4P scheme, think very carefully about what you want to incentivise. Incentivise means to improve, to move to the right of the curve. And if you start at such a high level of achievement, you've got nowhere to improve to. These are 2 intermediate outcome indicators from the Quality and Outcomes Framework, again for patients with diabetes, and this is BP and cholesterol below certain levels. And the issue here is about where you set the threshold. So if you see the dotted line for each of the individual indicators there, that's the maximum payment threshold. Go beyond that dotted line, you get the maximum payment. So most practices were getting the maximum payment from year 1, and again, there was nowhere to improve to. Contrast that with what Stephen said about having the staggered incentive payments for practices where you incentivise additional outcome. There was no additional outcome here, it was a purely summative yes or no. Now, one of the fears about the Quality and Outcomes Framework before it was introduced was that practices in deprived areas would not be able to achieve high scores. And in year 1, there's limited evidence that was true. So the practices in the black box there are the practices in the most deprived areas. By year 3, you can see that the performance, irrespective of the deprivation profile of the practice, was the same. So deprivation had no effect on performance by year 3. Now, this is what I like this slide, and I could stand here for the next hour and lecture to it, but I promise you I'm not going to. What's important here is when you have quality assessment, there are different stakeholders involved. Ask the patient. The patient's perspective is often very, very important. The patient's perspective in QOF is superficially important. It accounts for a certain amount of percentage of the income. But what the income is based on is, in my view, incredibly superficial. It's do a survey and talk about the results. There's nothing about the actual results themselves. And if you ask different stakeholders in quality of care what's important for them in quality, and also what they rate as quality, you're going to get different scores for practices. And the two key messages for this are, number one, on the right-hand side, you can see patient perspectives of quality of care over a 9-year period, which covers the introduction of the Quality and Outcomes Framework. And basically speaking, I'm not a big fan of big patient surveys. They're not very sensitive. They normally show high levels of satisfaction. They don't normally discriminate very much. So I don't believe in throwing lots of money at patient surveys. But what this shows is that continuity of care went down after the introduction of the Quality and Outcomes Framework. Now, the initial reaction to that is, oh dear, the Quality and Outcomes Framework reduced continuity of care. And it's possible that it had some impact. But there are also other issues involved in the UK, such as incentives for access in particular, increasing practice teams, increasing numbers of nurses playing a lead role, increasing number of part-time doctors, etc. So it's harder for a patient to get to see the same doctor anyway. So if you were going to incentivise continuity of care, you've got to take that complexity into account. And trying to attribute differences in one aspect of measurement of quality, in this respect from the patient's perspective, to the clinical care, which is on the left-hand side, is very difficult because there's so much noise. The left slide shows what's important for pay for performance is to have improvement over and above the underlying trend in care. And what you can see for the blue line, which is heart disease, for which there have been quite a lot of quality improvement initiatives in the UK prior to the Quality and Outcomes Framework, there wasn't really, after the introduction in 2004, any improvement in the underlying trend. It just stayed the same. What you see for asthma and diabetes is an accelerated level of improvement after the initial introduction of incentivisation. And that's the key message, which I'll come back to in a couple of slides. But what's interesting here is if you'd drawn a straight line from the 1998 to the 2007, you'd have got to the same place, but 2 years later. So what the pay for performance offered was an accelerated level of improvement 2 years sooner. And that mirrors the experience around the world and the systematic reviews which have been done for pay for performance. Now, one of the questions which was asked is what happens to non-incentivised areas? And this is actually quite difficult to do from a methodological perspective, because in order to contrast non-incentivised areas to incentivised areas from a quality and outcomes perspective, you have to have indicators which are comparable, for which you can compare data. And there's actually very few indicators with good, reliable data for non-incentivised areas. In many respects, the indicators exist because they're incentivised. But what we did find when we looked at indicators which exist and compared those in the Quality and Outcomes Framework, either as part of a condition in the Quality and Outcomes Framework, even if the indicator process wasn't, or vice versa, was that non-incentivised areas had poorer care, and in many respects a dip in care. And this reinforced two key messages. One, the rate of improvement was an initial acceleration, but was not sustained, so it plateaued after a couple of years for those where there was an incentive. And there was not a positive spillover into other activities, and indeed there appears to have been a negative effect on non-incentivised areas of care. The other question which is often asked is, what happens when you take an incentive away? And again, from an indicator perspective, so I was really interested in what Stephen had to say about this. From an indicator perspective, there's actually very little data. But there are 4 indicators, either in the Quality and Outcomes Framework, that there are diagrams, it's not just a blank slide. There are 4 indicators either in the Quality and Outcomes Framework or the Kaiser Permanente in the USA. And what these show is, if you've, the green dot, is it green? Yeah. Red dot is you've taken the incentive off. Green dot means the incentive's on. So there's one indicator where the indicator in Kaiser Permanente, the incentive's been stayed on, and it shows exactly the same thing. An initial improvement and then a plateau. The next one, this shows that you have an incentive on, you turn it off, performance goes down. The third one is there isn't an incentive, you turn one on, it goes up. And there's only one indicator we're aware of where an incentive has been turned on and on again. And that shows You turn it off, it goes down. You turn it on again, it goes up again. Now, in many respects, this is human nature. And there is the old chestnut of, well, the quality of care is actually the same, just recording's not quite as good. But I don't buy that argument, because good quality recording is part of good quality care. So, the empirical evidence on pay for performance across the world, there is strong evidence, but it's not particularly compelling. And there are unintended effects, so unintended consequences should always be looked for. But the basic summary for the P4P experience across the world is that it creates short-term improvement, but it's often impossible to even attribute that improvement to P4P because there's so much background noise. You think of the number of initiatives and quality improvement policies there are in most countries' healthcare systems. So basically, small gains, large cost. Now, so that's the P4P experience from the UK, if you like, and I just want to have a few slides on accreditation in the UK. We've had accreditation for quite a number of years. There's a Quality Team Development, and there's still the Quality Practice Award. Very few practices actually do accreditation. So the idea here was to develop an accreditation scheme which more practices would seek to do. And I was very interested in what Stephen said about before you talk to a practice, hear what they have to say. And we're very keen with this accreditation scheme that the practice gets accredited for delivering good quality care for their practice population. So you're not saying to practices, okay, this is what we specifically think you should be doing. You're saying to practices, identify what your practice population is, identify what their needs are, identify what your community needs are, and then address those. And again, rather than just yes or no, the criteria might be the same for any practice in the UK, but the evidence that they upload in support of a criteria might be different, because the practice characteristics, the demographics of their patients, the case mix, might be different. So the first domain here is called Health Inequalities and Health Promotion, and that's basically saying, do a health needs assessment, see what's important in your practice, and then everything else falls from that. You need to have good management to address those issues. You need to have the correct equipment and devices, the correct team, crucially a learning organisation, and of course the patient and carer.
I'm sorry to interrupt, Stephen. It's not a timing thing, it's just struggling with the...
Can you not hear me?
No, it's fine, it's just popping on.
It's just too loud.
It's worth just...
Okay, that's fine. Where was I? Yes, so what we try to do with these domains is to think about a patient's interaction with the practice and that the key aspects of that interaction are covered. And so why practice accreditation? So this is taking me into the more formative nature. It enables teams to improve their organisational quality of care. It's formative, it's supportive, and the idea behind continuous quality improvement. CQI was a big term 10, 15 years ago. One doesn't hear it as much these days. It demonstrates compliance with Care Quality Commission standards, which are going to be introduced into primary care in the UK. So if practices do accreditation, we were very keen to ensure that that would mean they tick the box for CQC. And that might also improve take-up. More practices might do it on that basis of ticking two boxes at the same time. It helps to complement revalidation, which is another initiative in the UK, and it supports commissioning consortia. So there's a combination here of core summative issues with formative practice-specific quality improvement. By addressing this accreditation scheme, you can help your practice tick the summative boxes, but you can more importantly enable yourself to do practice-specific quality improvement. So there's two stages in practice accreditation. We had to fight quite hard for that. The first is a core stage, if you like. So the underlying quality issues of practice accreditation, of organisational quality in those six domains of care. And these are more criteria on an achieved or not achieved basis. So it's more summative, with online assessment, with feedback. The second stage, and a practice has to do both stages to get accreditation, is far more developmental. It's more non-judgmental, it's more educational, it's more practice-specific. And the criteria are purposefully set up to be more bespoke. So there's more practice-specific evidence underlying them. And it's not just a pass or fail. So it's working towards, and that requires an on-site visit, which is in accordance, for example, with the European Practice Assessment accreditation scheme, which is used quite widely in other countries. So what are the benefits for the practice? Because there has to be, when developing these kind of schemes, something in it for the practice, rather than simply imposing it. To try and engage and infuse the team, build new skills, improve care with patients, engage with the community, as I said, pass CQC registration, and if possible reduce financial and legal risks. So we did a pilot scheme first, and I'm very keen on piloting. I think it's an important issue of quality improvement initiatives. Looking back, I think I really wish the Quality and Outcomes Framework had been piloted before it was introduced. But the pilot feedback from practice accreditation was that, firstly, the content made sense to general practice staff, which was a relief. It reflected team views of quality in primary care. So it aligned with professional values. There's another thing about trying to align any kind of extrinsic lens to professional values. They saw it as a worthwhile use of their time, and an opportunity to reflect and change the practice as a team. And I think the really important thing about the practice accreditation pilot was that those practices which engage as a team, rather than just one individual or two individuals sat in a dark room trying to tick off the boxes, got far more out of it. So it was, for those practices who saw it as an exercise in team learning, it was a far more valuable exercise. And this is the way that the accreditation is going to be judged in terms of the formative criteria. So either the practice doesn't meet the criterion, it doesn't meet the criterion, or it's working towards it. So and they get support in how they might get to that final tick box. And this is a nice quote from a practice in a deprived area, in an inner city area. And the value of formative practice accreditation. It gives you a chance to see your good points and your bad points. All practices, irrespective of their size, their composition, etc., have good points, they have bad points. And I think it makes you step back and take a reality check on what you think you're doing and what you're supposed to be doing. So, conclusion. There's no magic bullets here. There's no panacea. What's necessary really is a balance between accountability and trust to ensure that every patient does receive that standard of care, but also allow practices to be formative and good. And a 3D balanced approach, which combines organisational and clinical issues. It combines financial issues with professional incentives, allowing professionals to be professionals. And with a clarity of purpose. But the underlying message, I think, from the literature is, if you want to get quality improvement in a practice, have a macro, meso and micro initiative. So system level, PCT or health authority level, practice level, initiatives, all reinforcing the same point, and that will help you achieve quality improvement. But overall, quality should be about improvement, the model for improvement. And each practice should be allowed to go for the PDSA approach if they can. Summative yes or no's don't really allow this to happen. But what's really important is a practice or a practitioner becomes a learning organisation. Thanks very much.
Well, thank you very much, both of you. We have, again, a good 5 minutes for comments and questions and lots of hands. I'm just going to stop my timer now before it shouts at us in a moment. Work my way towards the back.
Thank you. Maureen Baker, immediate passed on with Secretary Royal College of GPs in the UK. Thanks for the R3GP practice accreditation demonstration, Stephen. I just wanted to say, and it partly comes back to the issue about professionalism and incentivisation. The model of general practice we have in the United Kingdom is a small business model. And actually, there's quite a lot to be said for that. There's a chap called Paul Corrigan, who's a former special advisor to Tony Blair when he was Prime Minister. Not necessarily always the greatest fan of British general practice. And he said at one point, if you want anything doing in the NHS, pay GPs to do it. And that's quite good. It is a way that you can get things done. And it seems to me that you don't necessarily need to make it a lot of money. It's more a question of saying, here is a problem, this is the reason why it's a problem, this is what you can do, and here's a little bit to help you do it. And I think the demonstration from Bolton sort of demonstrates that beautifully. So I think I'm just saying we can build on what we've got to get very good outcomes, and we don't necessarily need to beat ourselves up about it.
Randy Wertheimer from the United States, family physician. I gather from you it was a pretty lukewarm endorsement of pay for performance.
No, it's a lukewarm of the quality and outcomes framework, not necessarily pay for performance. I don't think the quality and outcomes framework is a great example of pay for performance because there's too much money attached.
Okay. So my question, I feel the way we're incentivized in the United States around pay for performance, as set by the insurance companies, sometimes interferes with the stuff that's changing based on the evidence. So we've been incentivized to do mammograms very early and very often, in a way now that we know the medicine is changing. All this focus on the glycohemoglobin when there's many other more important indicators. So it feels, could you comment on that? It feels like, there's a set that we pick because that's where the light is, they're easiest to measure, but it really may not be the correct.
Well, I think one of the fundamental flaws of the quality and outcomes framework, which is not necessarily a flaw of pay for performance, is the indicators that were chosen to be in it. Now, many people use the phrase low-hanging fruit. They were very easy to achieve. Now, irrespective of whether they were the right indicators at the start, they shouldn't have been in for the number of years they were in. There's ossification. And one of the issues about pay for performance is how much you make your scheme flexible and you change the indicators within them. And the same thing applies here about the quality and outcomes framework is a payment mechanism. So you pay practices. And we have to have indicators which we call quaffable. And in order for them to be quaffable, they have to be amenable to IT business rules, which are so incredibly precise and complicated that it means that anything really difficult in terms of diagnosis or treatment, etc., cannot be in the quality and outcomes framework because you can't write the business rules for them. So the question comes down to only things which can be measured from the way we measure the data can go in the quality and outcomes framework. It doesn't mean they're the only things which are important. So in my view, what's important needs addressing in different ways, and you shouldn't hamstring yourself by a data collection method, which means that really important things can't go in it.
Thank you. There's a gentleman had his hand over here. I think it also speaks, of course, about measuring things that actually matter, rather than just incentivising what you can measure easily because it's easy.
Thank you very much, Stephen. I'm Nero Siriwardner from Lincoln, UK. Just a quick question. In relation to transparency, can you say a little bit about how confident you are that, or what effect the QOF might have had on, and particularly targets on, for example, how practices dealt with blood pressure targets and whether there was gaming or anything like any evidence for that in the data that you've looked at. And the other question was around unintended consequences, and particularly around some of the measures, for example PHQ-9 for depression, and whether that might have led to, for example, inappropriate prescribing of antidepressants and so on.
They're two very important questions. The first one about gaming. The evidence for gaming is patchy. The official answer, I guess you would say, is that exception reporting, for which is about 5%, between 5 and 6%. But that it varies enormously between practices and between indicators. And it's interesting you mentioned the PHQ-9 indicator, because that's the one with the highest exception reporting. Overall, the evidence for gaming is that there is some evidence, but it's only some evidence, that practices have exception reported to boost income. And the work that Hugh Gravel and his team did in York did show that. On the whole, there isn't huge evidence either way. Certainly from a policy perspective, it's thought that GPs cheat by some policymakers. I don't buy that. We did qualitative interviews with some practices, and a couple of GPs said, yeah, we overtly went back and changed the records. And they admitted to that. So there's a limited amount of evidence that practices did game the system. But then when you attach 25 to 30% of a practice's income to it, perhaps you get what you deserve. The second one is about unintended consequences. Again, we looked at that from a qualitative perspective, because I think that's the only way you can really get at it. And there is some evidence that there are unintended consequences going on, and additional prescribing might be one of them. But it's one of those things where the research agenda for QOF about these issues hasn't really kept pace with the actual policy, in my view. So the evidence either way is patchy. I think your point about unintended consequences, though, is probably the most important issue for any policy initiative. Try and explore what they might be. So it's not a particularly helpful answer, but I think the evidence base either way is difficult.
Well, thank you very much, Jozé and Stephen, for a great presentation. In the interest of good time management, we're going to call it a day there, but our speakers are still at the front. If you want to have any comments or dialogue or questions, please do come and chat with them. Thank you very much.